Hello, welcome to my Med Planet. In this video, we are going to discuss about approach to altered mental status, and the following are the topics that we are going to discuss. Essentially, many conditions can give altered mental status, and we are going to look into some common causes from head to toe. CNS causes like trauma, stroke, tumor, subdural hemorrhage, subarachnoid hemorrhage, intracranial hemorrhage, delirium, and seizures, especially postictal, can give altered mental status. And infections like meningitis, encephalitis, and cerebral abscess are some of the other CNS causes. Both hypo and hyperthyroidism can give altered mental status. Lung causes of altered mental status are hypoxia, conditions like COPD exacerbation, which can cause CO2 retention, and pneumonia. Both hypoglycemia and hyperglycemic states like DKA and HHS can cause altered mental status. And some of the other causes are as follows. And some of these metabolic conditions can also cause this problem. The other causes are medications, alcohol, and psychiatric disorders. When a patient with acute altered mental status presents to you, the first things to do, other than of course making sure that their ABCs are okay, are check glucose for hypoglycemia and check for oxygen saturations for hypoxia. These are the two things which can be reversed immediately. If the patient is comatose and not responding, first make sure ABCs are okay and then try to get some history from the family. And these patients need extensive workup, including imaging of the brain and labs. Patients who are barely arousable with painful stimuli but unable to do full neurological exam also need extensive workup and history from the family. When patients with altered mental status present with no fever but following commands, then please take history and do complete neurological exam, including mental status exam if possible. If these patients have neurological deficits, then patients need workup accordingly with CT or MRI of the brain and early neurology or neurosurgical evaluation. On the other hand, if patients does not have any neurological deficits, then workup accordingly based on physical exam findings. Look for other causes, but still these patients might need imaging of the brain. When patients present with altered mental status and fever, history and neurological exam is again important. Look for sources of fever like meningitis, pneumonia, UTI, and these patients might have sepsis and septic shock too. We will look at the conversation between this patient and the doctor. He's awake, alert, and well oriented. He knows his additions. He can tell these numbers in reverse order. He spelled this backwards right. And he has normal neurological exam. Oops, but he is hearing voices. So this patient has good memory, good cognitive function, but abnormal thought process. So this patient most probably has psychiatric disorder. Patients with bacterial meningitis can present with fever, neck stiffness, and altered mental status, but this triad is present only in 44% of the patients. Some of the patients can also have headache, but 95% of the bacterial meningitis patients has at least two of these four symptoms. Very young and old patients can only present with altered mental status. The absence of Kernig's and Brudzinski's sign does not exclude meningitis. Patients can still have meningitis. According to IDSA guidelines, CT scan is not routinely necessary before doing LP except in these conditions: immunocompromised state like HIV or organ transplant, history of CNS disease like mass lesion or stroke, papilledema, abnormal level of consciousness, and focal neurological deficits. Steroids can be used in acute bacterial meningitis. Dexamethasone is a steroid which is usually used. It reduces hearing loss and neurological sequelae, but no overall mortality benefit. Benefits are seen in high income countries, but no beneficial effect in low income countries. Dexamethasone should be given before or with the first dose of antibiotics. It should be given for 4 days, and this is the dosing that can be used. The diagnosis and management of meningitis can be seen in a different video, which will be done later. Delirium can be seen in any patient, but is commonly seen in elderly patients, especially in the hospital. It is acute change in mental status with hallucinations, disorientation, and inattention. It happens quickly over a period of hours and days, and the mental status can be fluctuating. And predisposing factors like metabolic disorders or infections and dementia can be seen. And there are three types of delirium. First one is hypoactive. In this, patients have psychomotor retardation and they appear lethargic. And on the other extreme, it is hyperactive. They are agitated and restless. And mixed delirium. In this, patients fluctuate between hypoactive and hyperactive. And on the other side, there is dementia. It is gradual loss of cognitive function. Mental status does not fluctuate, and there won't be any hallucinations, and you won't see any other symptoms of delirium. Thank you very much for watching. See you in the next video.